What?
How you doing, Adam?
Oh, hey. It's when life comes at you sideways.
Hey, I am Jason. I'm 53 years old and I have prostate cancer that's metastasized to my spine. And on this channel, we talk about it. Today, I've got my good friend Adam here with us from Anything is Possible. We've got a couple of things we're going to talk about as we do an interview, and we'll be right back after the intro.
Welcome to Prostate Cancer, the road to recovery with Jason Stone, a stage 4 fighter. This podcast brings you support and insights from survivors, fighters, and medical experts. Join us for an educational and inspiring journey.
Hey, Adam, glad to have you here with us today. Welcome back.
Hey, thanks, Jason. I appreciate you having me. It was an eventful morning.
It's been a crazy morning. We've had some issues. I've had some issues on my side with Riverside, and it's just been it's been fun.
Yeah, I think the whole world is having technological issues right now. So it's appropriate, I guess, for us to continue with that theme.
That's true. That's true. So one of the reasons I wanted to get you back on is you had some PSMA PET scan done recently, right? And you got some results back. Do you want to talk about those results a little bit?
Yeah, no, I appreciate that. Yes, so I am, as we will all find, especially guys with advanced prostate cancer like we have, we're at a kind of fork in the road with what next steps will be. So for those who aren't familiar with my story, real briefly, I'm on androgen deprivation therapy with a first and second generation ADT drug. In my case, it's now Eligard. I started out with Degarelix, switch it to Eligard every 3 months, and Erlita, which is the oral capsules every day. So that's my first and second generation. And then on top of that, I did a 6-round course of docetaxel or Taxotere, which is chemotherapy, which I'm going to say it sucked, but it didn't suck in the classic movie way that it sucked. I wasn't throwing up over a toilet. I wasn't on my deathbed or anything like that. It just, had these side effects right here. Made me look like a cancer patient, which I am. So that stopped. My last chemo injection was on the 11th of January. And you have to wait, or they recommend you wait 4 months to do another PSMA PET so you don't get erroneous uptakes. And I did that because the PSMA PET is going to help me determine what my next steps are.
Yeah, you got to know where you're at. You know where you started. You got to know where you're at to make a decision, right? Is everything you're doing working or not working?
Exactly. So I had an initial PSMA PET probably 2 or 3 weeks after initial diagnosis. And this was when I was just on, I hadn't even started the Degarelix injections. I was only on the Erlita, so the daily oral pill. That's the only thing I was on when I had the first PSMA PET. And then since then, I had an initial baseline contrast CT, which is very different from a PSMA PET. And then I had a second contrast CT after the 4th round of chemo to see if the chemo was working or if the cancer was getting worse. And then, of course, I recently, about 2 or 3 weeks ago, had that PSMA PET. Now, I mention all that because it's important, number one, to differentiate the type of scans, and number two, to kind of get my comments on what I think was working. Because jumping ahead, my doctors are saying, the radiological oncologist and my old medical oncologist are saying, hey, the chemo, you did awesome on the chemo. This is all due to the chemo. I don't believe that. I could be wrong. I'm not a doctor. But anyway, while we're here, the difference between the PSMA PET and the CT, a CT scan is almost like, and I'm definitely going to get this wrong, it's those blurry images. They look like x-rays of your body, that they're kind of these fuzzy images that you're trying to pick out, black and white, or grayscale really, where the tumors are. Whereas a PSMA PET, the contrast CT, they're really just looking on stuff that's inflamed, that is bigger than it should be, or, dots that really shouldn't be there.
Yeah, it's hard to
on a,
see. It's hard to see what you're looking at, and they can't tell, is this cancer, is it not, from the CT scan. It's just they have areas of concern.
exactly. And so on your PSMA PET, they inject you with a radioactive isotope, and that radioactive isotope seeks out specifically PSMA cancer cells, or prostate-specific antigen cell cancer cells. And so those cancer cells will eat or uptake that isotope, and so they will shine brighter than the background. And so that's why you have things like SUV uptake or standardized uptake value. They have a level that you'll, on your scan results, you'll get that talk about, okay, look, this uptake value was really high. And 2.5 is the threshold. So according to the Mayo Clinic article that I read. So anything above 2.5, the higher you get, the worse it is. So the more confident,
the more cancerous it is, the more confidence.
Exactly. Yeah. So, my initial scan, there was a lot of over 20 values in the lymph nodes and the bones. And in reading it, so I want to kind of, there's so much stuff here. It's like, I want to jump around.
Let me just unpack this huge box.
Yeah. And try to be concise so we can, maintain and everybody kind of understands what we're talking about.
The more info we get out there, the better.
Yeah. So, okay. So, again, on the initial scan, and again, the report is only like a 2-page report, if that. And, so they'll use a lot of generalities because the person who's reading out the report's not going to go through every single thing on the pictures. And I'm finding it's kind of hard to get a doctor that'll actually go through the pictures with you. But I did in both cases. I've seen the pictures for both exams. So anyway, I came away with that first PET scan thinking, wow, I've got serious disease, but it's only in a couple of spots. So then this scan, I had Mets that they detected, but the uptake values are significantly lower. So we're talking, 4.4, I think or maybe there's a 6 in there somewhere, but 4 or 2.7 or 3.2.
Way less than 20.
Nothing at 20, nothing in the tens. So from that perspective, really good. And then there's less Mets that, especially on the scan, when we look at the pictures, they're less. I was expecting there to be a lot less than what it was. And the reason why I was expecting that was because the contrast CTs, I was told that I was clear in my chest. Whereas the PSMA PET is saying, well, no, we see something that might be in your chest. But the standardized uptake value is only like at a 2.6 or a 2.7. So when I went over the scan with my radiological oncologist, he was scanning through the chest. And he's like, you don't have anything there. This might be something, but it's probably nothing just because of what the background noise is.
Could be damage from an old injury.
It could be a lot of things. I mean, so that's one of the things for us, and especially other guys who are going through prostate cancer, advanced prostate cancer, is you're going to hear a lot of different things, and you have to make informed decisions that are going to affect the rest of your life based on what doctors are telling you and what you can research. And so again, it goes back to what we've talked about before, being your own advocate. So, like when I say, I said in my last video, I was disappointed because I thought it was going to be a lot clearer, because I thought in my mind that my next step was going to be localized radiation. And I thought that was off the table based off this last scan.
Man.
But as to kind of sum all of this up, in a macro view, I had very good response to the therapy that I'm on.
It sounds like a lot of them have been knocked down significantly, which means everything's working.
Yes.
Maybe you didn't hit curative as fast as you wanted, but you're still headed there, right?
Yeah, exactly. And so, and I don't know, the last time I had a PSA check was in January, and it was 0.04. So, pretty close to undetectable, if not already undetectable. And I don't get another one for another week or two.
Okay.
But, I mentioned before that the doctors, the radiological oncologist and the medical oncologist, they are contributing or attributing this response, this really awesome response that I've had to the chemo. And this is why I don't think it's the chemo.
Okay.
First, so I mentioned that when I did my first scan on my first PSMA PET, I was only taking Erlita. And my PSA at that time was 570. Then I started taking the Degarelix, the Degarelix. Before I started any of the chemo, my PSA was at 15 or something.
So just off the hormone therapy, dropped your PSA just straight down.
Exactly. Just off the first and second generation, I dropped the PSA straight down. And remember I said I took a baseline contrast CT before I started the chemo. Well, my 4-week CT scan, the exact words that they told me was stable, no progression. So if my CT scan is the same before I started chemo and after 4 rounds of chemo,
is that really helping?
Exactly.
Interesting. Exactly. Okay. Interesting.
Yeah.
So, and when I said all you were doing at that time is the hormone therapy, that's not entirely accurate, right? You'd made some major life changes, which we've talked about in previous episodes, but they're always worth revisiting because I go to the prostate cancer support group on Facebook, and somebody always asks, what's the right diet for somebody with, I've just been diagnosed, what's the right diet? And you always get a couple of chowder heads in there that say, hey, eat what you want, live your life how you want. I'm like, I've got personal OE now, personal experience that I should not eat what I want. There is a path, a nutrition path to help. And you went full non-dairy, gluten-free, and plant-based proteins. You're not vegan, you're not entirely vegetarian either, though, right?
Yeah, exactly. Yeah. So one of the doctors that I went to at Memorial Sloan Kettering, she recommended, she's like, look, please for me, eat red meat every once in a while, eat fish. You can eat fish more often. And so I do that. I eat red meat, lean red meat once a month is about what I do. And the reason for that is because of the vitamins, specifically the B vitamins that they have that your body metabolizes better than getting them through multivitamins. So yeah, I'll eat a fillet once a month, and I'll eat fish generally once a week, and usually it's salmon, just because that seems to be the best fish. I preferably like the white flaky fish is better, but I do eat salmon more. So yeah, so you're exactly right. I made those lifestyle changes. I'd always been active, so I maintained that activity. I walk every day. Since I got the port out, I got really more vigorously into the weight bearing exercises until I pulled my back doing some about a week and a half ago, and it's just been a pain in the back.
A pain in the back.
But yeah, so it hasn't been healing. But of course, I don't have any testosterone to help the healing and all that kind of stuff. But one of the things I wanted to mention too with the red meat is I mentioned early in my videos about my urologist saying, hey, I asked him, hey, what can I do? And he said, don't eat sugar. Mm-hmm. And of course, you don't want to eat processed sugar, which I don't eat processed sugar anymore. But our cancer, what I've heard or read more, especially like with the PCRI videos and Dr. Eugene Kwan and some of those videos, our prostate cancer metabolizes meat, eats meat more. Okay. Those proteins in meat more than it does proteins. Sugar. Yeah, exactly. The animal proteins it metabolizes more than it does the sugar proteins.
Well, that matches something my radiation oncologist said. He said, it's okay to eat animal proteins. He said, what we're finding out is that too much is bad, and it's more how we cook it. So if
Yes.
you're searing and steak tartare might be on the menu now.
Yeah, exactly. Yeah, but yeah, and you're exactly right. And so, like you were saying just before, the diet really does matter. At least it's. I can notice a huge difference.
Yeah,
I
same.
noticed, I noticed a huge difference in how I felt, even going through androgen deprivation, even going through the chemo, having changed my diet so drastically. And and it's not that hard. I don't, there are some things that I miss, yes, but again, it's not, it's plant based. It's not
Yep.
vegan. I'm doing it for my health. I'm not doing it for any, religious or personal convictions that I might have, other than the conviction that I would like to be around on this earth,
Right.
longer
Staying
than
alive.
yeah, exactly, exactly, man. Yeah, I had an alarm set. This is awesome.
To start this, man, I should have.
Yes, I did.
I don't know why I thought you were Eastern Standard Time. Well, you're in Florida, right?
Yeah,
How is
everybody thinks
Florida not on Eastern Standard Time?
the majority is, but not where I'm at.
Not where you're at.
Yeah, you've got this little point on the peninsula and the panhandle that's on Central. That's where I am.
I'll make a note of that next time.
No, my bad. I mean,
Yeah. Got you out of the gardening. I got you out of gardening.
Yes,
There
you
you
did. Yes, you did. So, oh man, this is awesome.
Now you talked about a lot of that. You talked about a lot of that where you're at with your scans. You actually went through the numbers in your video. I'll link the video. I'll link to your video in the description. And that was your episode number 17, right?
Yes.
You've been doing these videos talking about your journey as well. So getting information out there to help other people.
Yeah, definitely. And I've, and thankfully, and thank you, for being on with you. I've kind of gotten some other people watching the videos that I've been able to help. And I mean, and like you said in your podcasts, the point of us doing this is just to help other people. Yes. And let me back up. The point of us doing this, at least for me, it helps me. And, one of my goals in life is to leave this world a better place than I found it. And so if I can, in doing that, is helping other people. And if I can help that one person, then that is helping me to my goal selfishly. But, it helps validate what I'm doing. And us doing these podcasts together, or vlogs, or whatever the right word is.
Yeah, I don't know anymore.
Yeah, I mean, I'll call them podcasts. But, it seems to be helping other people, so, I'll keep doing them. And again, and it has really been helping me too, because it helps me talk through all this stuff. I mean, look, you asked me about the PSMA PET. I've talked for 15 minutes just on this whole thing with PSMA PET. And we got a whole bunch of stuff to get through.
That's fine. It's fine. I don't even know why I bother putting a script together for our conversations.
Well, I think honestly, these could be 4 or 5 separate episodes, for us getting together, and we just should get together and just do this. Say, all right, last time this is what we talked about.
Oh man. Well, I've been in kind of a slump. And I did a couple of videos, driving home from work like a madman, crappy week. And then, and I don't know what it is. And I hear comments from a lot of people saying, and I'm just down this week. It's just it's almost like there's something in the air, something in the water. Cause a lot of people have been affected on this. And whether it's the weather, it's been cloudy, the weather's been crappy, whatever it is. Yeah. I'm feeling better today, and I'm feeling better. You get me laughing, and that's awesome.
Hey man, anything I can do to help.
But yeah.
Well, so with you, do you think? I know you've been still keeping up with the exercise. I know you took up the rocketry, so I mean, you're doing stuff that you enjoy. So you got the Big Mama Jama? Nice. When are you launching that thing?
Well, there's another rocket launch on April 13th. So I've got the first layer of fiberglass on the fins curing. And then I got to do a second coat on it. And then I got to do a bunch of prep on then the booster section will be just about done. And then I got to work on the front end of the rocket. So I'm hoping April 13th I'll be launching that sucker.
Awesome. I hope you do a video on that. I'd like to see that.
Ooh,
I
yeah.
think that'll be good. Well, because it's important, I think, and and you've mentioned it too. Cancer cannot be your life. Yes, it is your life, but you've got to live. And if you're not doing things that you enjoy, treatment's going to be harder. It's going to be harder on your family, and it's going to definitely be harder on you. And so, doing those things that you enjoy, whether it's vlogging, whether it's the rocketry, for me, I really enjoy working out. I enjoy spending time with my boys. That stuff helps. It helps make it go better.
Yep.
That quality of life.
Yeah, that hits home because I've been doing these episodes now for 7 months. This is number 20. This is a milestone.
Congratulations.
When I was doing an interview with a guy who helped me improve my podcasts, Brian from Summit City Studios, he had asked me, one of his questions in the interview was, so what's your plan, or how many episodes are you going to do? And I was like, I didn't see an end point in sight, but maybe there should be, because when I look back, I've done 7 months of these videos now. I've done 7 months of treatment. Cancer has become my life. And I'm trying to break back out of that, because if you live in that world a lot, as answering the comments, constantly looking up information, constantly looking for what can I talk about. And you're talking about cancer, you're thinking about cancer, you're researching cancer. That wears on your soul after a little while, and I think that's kind of driven the downside of the roller coaster. So, like you say, I'm trying to forcibly break out of that. And I was like, tried a couple other hobbies I used to do. Did a lot of leather work. I just don't find myself interested in things I used to be interested in.
You can't force it.
Nope.
You can't force it.
So I started looking around, like, what did I used to do that I haven't done in a long time? And that's where the rockets came in, is trying to do something I haven't done in a really long time that I know I loved as a kid, kind of bring back that inner kid, so that I'm exploring and learning something different. And I don't know how many more of these I'm going to do. I don't know if I'm going to keep going. There are some episodes I still have in mind I want to do. My radiation oncologist just announced this week that he's moving to Florida.
You know where?
I don't. I'll find out. I don't know where. He's an amazing radiation oncologist. The Tri-Cities here are going to miss him incredibly. Dr. Luenda.
Okay. Yeah, because he had the book.
Yep. He's got 2 books out now, and
I've got one of them.
He's an integrative oncologist, so he does a lot. He looks at a much bigger picture, which is awesome and important for us, right?
Yes. We don't have one down here, so I hope he's coming to my area. I doubt it, but I hope he is.
Yeah. Oh, that'd be cool. Yeah. I'll have to tell him. I'll find out. But,
so what are you gonna do with him leaving?
Yeah, I don't know. I don't know. That's a little scary. Now my radiation should be done, so I did but I won't know until August or September, because I did the radiation to my prostate, I did the radiation to my spine, and now I'm just dealing with the medical oncologist. So he was my radiation oncologist. I still have a medical oncologist that's here through the Tri-Cities Cancer Center. But what if? I've got some concerns. I got to bring these up to my upcoming visit. I've got some spots, some bumps on my jaw that have grown, some lumps, and they've started to hurt. And so I know that when the cancer metastasizes, it moves and it goes to the bone. One of the bones that it easily goes to is, besides your pelvic bone and your spine, is also your jaw, your lower jaw bone. Huh. So but my PSA, I got my PSA tested last week, less than 0.1. It's awesome. It's still undetectable. And so it shouldn't be, but I get worried. And if it is, so if I go get a scan and it is, then, and he's moved, we don't have a radiation oncologist in the area. I don't think we do. I got to find out if we have others.
You're driving, I guess you'd be driving to Oregon somewhere or something, huh?
Yeah, Spokane. If anybody is in Washington, Spokane has great cancer centers, and so does the Seattle area. So I might end up just taking a little time off work and going over to Seattle. But
yeah,
who knows?
Yeah.
But
shoot me.
yeah, so I do want to do a video with him before he leaves. That was the whole point of all that. See, I just babble.
No, you're good. Look, hey, we talked about the scan. We got, some stuff on the rocketry. We got the radiological oncologist. I mean, we're moving, which actually is a great segue because, as you know, I had a meeting with my radiological oncologist. And so, because like I said, what I thought from the stuff that I was reading, like PCRI, there has been some research about people achieving cures, and I don't like using the C word, lightly, with localized radiation once you're localized back to the prostate or maybe a couple of mets outside. Once I'd gotten my report, I thought that radiation, like I said, was off the table. That said, I met with the urologist, and the urologist wanted me to see two things what the urologist said. Number one, the urologist is supposed to refer me to a provider in Pensacola that could do lutetium 177 or Pluvicto.
Yeah, Pluvicto. Yep.
Yeah, Pluvicto. Yep. So, because he says that I'm possibly a candidate for that, which, again, for anybody listening, if you're just diagnosed with prostate cancer, ask your doctor about doing, and you have mets like everywhere or multiple mets, ask your doctor about lutetium or Pluvicto, because they're doing studies now because the results have been so good. They're doing studies now to bring that up earlier in treatment instead of starting automatically on ADT. So anyway, I'm supposed to go see somebody in Pensacola about that, which they haven't called yet. And then I got an appointment that I had Wednesday with my radiological oncologist. So I met with him. And that was a good 30-minute, probably the best 30-minute conversation I've had with him. He is a force of personality. He is one of the, according to him, he's one of the nationally recognized experts on lutetium 177.
Oh, sweet.
He's one of the top radiologists out there that writes a lot of the procedures and therapeutic procedures for stuff that we go through, you and I go through.
Okay.
So lucky to have him. And anyway, us going through this, we did go through the pictures, and he was saying, according to him, I really don't have a lot of cancer left, and he thinks that it has localized enough to do radiation.
Holy smokes, that's good news.
It is good news. Now here's where it gets weird. He said he would be interested. So number one, he's like, look, I want to be aggressive because you want to be aggressive, and you're young, and so you should be aggressive. So your answer to any next course of treatment should be yes. So whatever next card is on the table, it should be yes. He was talking about doing the localized radiation of the prostate and the couple of lymph nodes that are still, and they're not even that swollen, but that are still kind of around, and that made me cancerous. Doing those, plus doing another round of chemo with Jevtana, vice the Taxotere, obviously.
Yep.
I'm not a fan of that. I don't want to do chemo again, but I understand what his reasoning is. He had said he really didn't want to talk to me about the lutetium because he wants the doctor who is going to give me the lutetium or the Pluvicto to talk to me about it. But some of the things he hinted to that I wasn't considering before is, all right, I've already had the Taxotere, the docetaxel chemo. That chemo has done some damage to my bone marrow and to my system in general. The lutetium is going to do more damage because it's local radiation all over the isotope all over the body. and I'm saying this definitively, it's more like it could do more. It could give me additional damage because it's my bone marrow is already weakened. So they're just questions that I need to ask about possible side effects that I need to be aware of with going forward to the lutetium. And where the benefits of the lutetium would be that it'd go all over the body, whereas the radiation, he's only going to be localized in the prostate and maybe a couple of lymph nodes. And the lutetium, but the side effects are going to be relatively low with both, but the long-term side effects with the lutetium might be worse given my current state.
You might feel more radiation sickness from the lutetium throughout your body as it's covers all the mets. It's still a gamma emitter. And so when you have a gamma emitter in several spots in your body, that's going to give you, it's going to increase your chances of feeling the radiation sickness.
Are you sure it's gamma or beta?
Turns out
my notes here
right here.
because I mean, yeah, that's obviously a big difference here.
7, a beta or gamma emitter. So I thought they were looking at a beta emitter. Oh, shoot, you're right. Many beta emitters, uranium, thorium. Examples include, oh, wait a minute. Common beta emitters, strontium, tritium, carbon, phosphorus, nickel. Why isn't this an easy answer?
Yeah, I know. We should tell you. The thought that I had, we've got some literature around here somewhere, but this place looks like a bomb went off. I'm nowhere near as neat as yours, and I have a lot of jealousy.
Here it is. I got the definitive answer. LT-177 is a beta emitter, so you're right. So it won't. It's not as penetrating. It's blocked. It'll hit those surface cells, and that's so you're a lot less likely to experience the radiation sickness. All right, I'm glad you caught that. Lutetium-177 is an isotope used in targeted radiotherapy for treating various types of cancers. It emits beta radiation, which is effective in damaging cancer cells while minimizing the impact on surrounding healthy tissues, which is why it would be such a fantastic opportunity to do that. Okay, thank you for that correction.
Yeah, no worries, man. Yeah, so that's kind of what's on the table, and so my radiological oncologist wants to be aggressive, as do I, and I think he's saying at this point, in his opinion, you just keep going after this thing, throwing stuff at it so you just beat it down because you're young enough. He talked about the side effects with radiation. My concern with the side effects with radiation were damaging the urethra and stuff like anal bleeding and, of course, erectile dysfunction. And some stuff that I had read before I talked to him, had those concerns as pretty legitimate. However, when I spoke to him and I posed those questions to him, he said, look, if, he called it a perfect peer. If you're a perfect peer before radiation, you're going to be a perfect peer after your radiation. Nice. This is not counting what ADT is doing to you.
Right,
but, right. And the same thing is like if you're a rock star in the bedroom before radiation, you're going to be a rock star in the bedroom after radiation.
Yeah, the the surgery would be more impactful because you have to cut a section of the urethra out, which can cause damage, leakage, and they may hit the nerves. They may have to remove the nerves, which affects performance. Yeah. So doing the radiation therapy. Have they talked at all about doing something called a space or gel?
So I'm glad you mentioned that because it was a question that I should have asked him and that I wanted to, and I completely forgot. Yeah. Now, if he really is the authority that I do believe that he is, then I'm sure it's going to do it. But that's very important because I do want the space or if we're going to be doing, the therapy, the radiation.
The more shielding you can get between the target area and other sensitive areas, the better. And that's what that is. It's just a little 1/4 inch thick piece of hydrogel that helps shield the colon. So, which is huge because guys that used to get radiation 20 years ago would experience, like you said, rectal bleeding, colon bleeding. They'd experience colon cancer. The treatment caused other problems. And this is one of the huge things they've improved.
Well, and the key with guys like you and me who are relatively young is, look, prostate cancer this advanced usually presents itself in guys that are 70 or older.
Yep.
And so, radiologists are not as concerned with super long-term effects because, you've only maybe got 15 to 20 years, of life left on average if you're going by, the averages.
Yeah.
Whereas, my oncologist brought this up to me. He's like, with it showing themselves up in guys like us, he's like, look, there's a possibility that 30 years down the road, when I'll be 80 or even, older, your chances of blood-borne cancers are higher, or getting a fistula are higher at that point, but they're still low. And, so what's low? Is low 20%? Is 30%? I mean, that's low, percentage-wise.
Right.
But look, and he was very true. Look, at 80 or 90, if you're coming to me and you're then dealing with that, you're giving me a hug because, I still gave you. Yeah, but he's right. Hey, I got, especially the quality of life.
Yeah,
if I can, if I can get this radiation, knock this thing down, and then, or lutetium to gather the rest, then yeah, awesome. But there's always a but.
Mm-hmm.
And, and so in this case, the but is, he brought up, look, this is what we can see, and this is what the PSMA can see. And just like the CT scans, you can only see what it can see.
Yeah.
The PSMA PET is only looking for those prostate cancer cells, and some PSMA cancer cells can do the whole matrix thing, where they're get out of the way of that isotope to where it's not going to uptake on that isotope. So it's still important to get, bone scans, which I haven't had one.
Okay.
So all I know is where the PSMA PET is showing me that I've got. Now I don't have pains other than this pain in my back that I'm really hoping is that I'm hoping is a muscle. But and I think it is. But but other than that, you don't really know. And guys like us that have had cancer, just like you said on your podcast before, now that we've had it, from now on until the end of time, anything that we like, any tick, any abnormal discharge, any pain, lumps on the jaw. Like me, my vision has taken a hit since chemo.
Oh yeah.
I'm like, is this a different cancer?
Right.
But it is, it is what it is. So again, for my stuff, overall, very positive. There's some, there's still steps to be taken. I'm at that fork in the road. And yeah, so it looks like now I'm going to be deciding between lutetium and the radiation. I have another appointment in April with the radiological oncologist. Like I said, I got to meet the lutetium guy. And then I've got another appointment in April 2nd with my new medical oncologist. So that's where I am.
Okay. Wow. Holy smokes. That's a lot to take in.
Yeah.
Yeah. Radiation, lutetium, and they even offset maybe even doing
Another
more.
chemo.
Yeah, chemo. Man, I can understand not wanting to do that.
And so Jeff Tana, and here's the funny thing. So I did docetaxel. And the reason why most people do Taxotere and docetaxel, according to PCRI and some of my oncologists and stuff, is your insurance wants to pay for Taxotere and docetaxel because it's cheaper.
Oh.
So Jeff Tana, what they say is most people tolerate Jeff Tana better than docetaxel, Taxotere. I got to choose what name to just call it that, but it's the same thing.
Yeah.
But they're both almost identical. They're just variants of the same base, whatever. Maybe it's the bark from the yew tree for both of them. I don't know. But their root is, no pun intended, the same.
Yeah.
And so they just have some different modifications. But the Jeff Tana is supposedly better from a tolerance standpoint, and it has the same effectiveness, the same efficacy. It's just more expensive.
Yeah.
So
I can see why the medical or the insurance community is like, well, how much is it really worth the better? Well, yeah, to the patient it is. Yeah, but this other one's cheaper.
Well, exactly. And your insurance companies will generally approve Jevtana because Jevtana is usually given once you become resistant.
Okay.
Just like lutetium right now is usually given once you become resistant. But you can give it before then, just like, my doc's talking about possibly doing it here. So,
Yep. Yeah.
well,
I remember a guy in the comments of the prostate cancer, we were talking about lutetium. I brought that up as, hey, ask about this. And they're like, oh, no, you can't do that until the very end. No, once it's approved for use, it's approved for use. It's not just because the tests were for late, post castrate resistant, post you've been through chemo, you've been through all the treatments, and now you need more. That doesn't mean that that's what you have to wait for. So I'm glad you brought that point up because, yeah, there's a lot of misinformation out there in the forums and on the Facebook pages and stuff. It's important to be careful about what questions you ask and what information you get from some random person out there.
yeah, definitely. And another important question to ask is, okay, if I do this treatment, what other arrows in my quiver are this going to take away?
Yep.
So, because there's a sequencing issue. So, you need to know, hey, if I do this, will I be able to do it later? Or if I do this, will I be able to do this other one later? And the answer might be no. And, so that's important. So like if I do radiation, well, like for example, if you do surgery, radiation is probably not something you're going to be doing in the future.
No.
And the same thing with other treatments. So it's like, it's crazy, man. But
yeah, it's nuts. Well, one of the things I wanted to talk about today was addressing questions from comments on the Facebook groups. Now, I tried sharing. We're using Riverside today instead of StreamYard, and I tried sharing the snippets I took, and unfortunately, it won't let me. So I'm just going to read the question.
So we up a river without a paddle is what you're saying.
Yep. All right. So this was on the Facebook group, Prostate Cancer Support Forum. As I prepare for my journey, what doctors will I need to consult, and what is best way to find great doctors who specialize in prostate cancer? I do live in, and then the rest doesn't matter. So the question is, what doctors do we need, and how do you find them? I think that's a great, and you've searched the country for doctors, as you're seeing a doctor in New York. Is that right? And you're in Florida?
Yes. Yeah. And this is, a lot of this is ability, and means, I guess. And, or just like the Batman who you had on before, he saw the guy that we watch, he got to meet Dr. Schultz for the Prostate Cancer Research Institute. And, if you've got the money or the ability to go see doctors like Dr. Eugene Kwan or Dr. Schultz, or one of the
Gio Espinoza.
Yeah, exactly. Who's a integrative urologist, then you do it. But so there's a couple things. One is the doctors themselves and how do you find them, right? Mm-hmm. And so, of course, you go to the internet, you talk to people who've had prostate cancer. You can do a search on top cancer doctors. Generally, what I found and I'd be interested in what you found, what I found when I was diagnosed was I was told about two primary cancer research centers. One being Memorial Sloan Kettering in New York, which is generally considered as number 2, and then the top one, which is MD Anderson in Texas, and they've got a satellite campus in Moffett, which is I think close to Tampa, in Florida. But and I think they may have swapped. And we can get into that, or opinions on why that is.
Interesting.
But so that's where I started, and so from that, I was thankful I had a urologist buddy who was a good friend of mine from the Navy that was practicing in Washington State, and he had a buddy who was more specialized in the oncology part of urology. And he said, hey, you need to go to Memorial. If I had prostate cancer, I'd go to Memorial Sloan Kettering. And and see this doctor. And so he got me in with this doctor. Dr. Slovan is who I saw. She was like voted like top female medical oncologist a couple of years ago. And I'm glad that I did, because I'm in a rural area. And so the oncologist that I saw, the first oncologist, my urologist is great. And so this is where I talk about fit. And so I have a good fit with my urologist. We feed off each other. I can understand. We can communicate. My medical oncologist that I had, who from a professional standpoint, I don't have an issue with him, but it wasn't a good fit personality-wise or how it went. But I went and got that. So I saw him, and I went and got that second opinion at MSK. And she agreed with everything that the medical oncologist down here was seeing or saying to do. So I did that, but again, the fit wasn't there. So what did I do? I switched. I talked to other people, and I switched oncologists to the new oncologist that I'm seeing now.
Well, good.
Medical oncologist. So anyway, that's how I found it. I mean, how did you find yours?
So I relied heavily on recommendations initially. What I was told was there was two major cancer centers for prostate cancer. One was the Mayo Clinic with Dr. Kwan out of Minneapolis.
Yep.
And then the other one was in Seattle. And I don't know, they didn't give me a specific doctor's name. They said that's one of the forefront of all the new treatments. That's where a lot of the tests are done, a lot of the trials. And so if you want to go to Seattle, that would be a great choice. And I asked around, a friend at work had cancer. He had chest cancer, not breast cancer, but cancer in his chest around his heart and stuff.
Oh, wow.
And it was a really tricky area, right by the lungs, right by the heart. And he was cured through radiation by Dr. Lawenda. So he said that he was amazed at how well he did his job. And so that kind of like, well, if it's right here in the Tri-Cities and I've got this absolute great recommendation from this person I absolutely trust, then yeah. And you have to have one of the other first part of their question is, what doctors do you need? Well, you need a urologist, you need a medical oncologist, and you need a radiation oncologist. Those are the three minimum. If you're not talking to three doctors, then you're not getting all the information you need.
It's funny. So two things. One, with the doctors, because you're exactly right. And, I completely agree with what you said there. And it also, you can read other people. Like when I first got cancer, I read a book by Chris Wark, and he mentioned, in addition to those, he mentioned the integrative oncologist, or maybe even an Eastern medicine doctor. If you really want to open up yourself to different things. So I mean, you can get other pieces of the puzzle. But I couldn't agree with you more. I think at a minimum, you need the medical oncologist, your urologist, obviously, and your radiation oncologist. Because your medical oncologist, a lot of them, what they're going to do is, once you're done with chemo or surgery, they're going to release you back to your urologist, and then you guys are going to do treatment until the cancer becomes resistant or something else.
Yeah, and my medical oncologist was like, he was okay. Not a great conversationalist, and he was very down to business. We're just going to do this. We're going to do this. But once I got my treatment started, then I got moved down to the next level. I don't mean that down to, but the person that because he's the one that they send everybody to get going, that he does the initial, gets everybody rolling. And then the sustainable piece, I'm trying to think, I'm babbling while I try to think of the right word. The continuance of the treatment is referred to a different doctor. Now, that medical oncologist that I'm seeing now, she is fantastic and absolutely is interested in my symptoms, in my treatment. I was a couple weeks ago, I had some symptoms and I was getting worried, and I just sent a message on my chart saying, hey, I'm worried about this. She said, you need to go to urgent care. You need a urine analysis. And then she referred me out. I'm going to get some scans, and we're going to make sure we're going to put you on antibiotics just in case until we get the results back. And so she went right after it. And it's that level of individualized care really makes me feel better. Yeah. So, yeah. Finding doctors that's close by that has that level with is good.
Yeah. Well, the other thing I wanted to bring up too is, you mentioned that you had heard the top two places where Dr. Kwan is, Mayo Clinic, and then the Seattle, which I know Seattle's great because I have a very good friend who had breast cancer, very aggressive breast cancer at a younger, like I think she was 30 or younger than that, and that's where she had gone. But yes, just so all that information out there, it's different. I had as MSK, and because you were talking about Seattle doing the cutting edge research, my urologist buddy in he's outside of Seattle. He was telling me the cutting edge research is done by a guy in MSK.
Right.
So it's
how do you sort through all this?
Right.
I don't.
It's sad. It's not sad, but it's scary because you take these research hospitals like Mayo, MSK, MD Anderson, even Seattle. And the point of getting connected with one of those is if your cancer is aggressive to the point that you need some new novel treatment, and so you need to go after one of these trials. Yep. And the fact of the matter is these trials are generally it's like teams, like football teams. This player plays for the Saints, or this player plays for the Vikings. This trial is at MSK. This trial is at Seattle. So you may not know about this trial, or your doc may not know about a trial that might be beneficial. And again, it goes to your being your own advocate, doing research and saying, "Hey, doc, I've seen something about this trial. What do you know about it?"
Yep, absolutely. Well, let's get on to another question. I got two more questions here. I want to bring
sorry,
up.
I'm by the way.
No worries, no worries. This is all great. So this one is a tough question. He presents a lot of information. His prostate biopsy results came out and it shows cancer. Okay. Most of the Gleason scores are 4+5, which is a Gleason of 9.
Yep.
And it says perineural invasion is present, which means it's broken out of the prostate.
Yep.
It says, I'm 62 years old. I have no symptoms. My PSA was 52. How many years can I live? Man, right? Doesn't that question just hit hard?
It does, but I mean, I think that's kind of the wrong question. I mean, who? Because like what we said before, you can get hit by a bus tomorrow.
Yep.
And or get struck by lightning, or something else, and die of something completely different than your prostate. The question to ask is not how long you're going to live, because I would say those. From what you've told me, that's completely treatable. You've got a lot of options. There's a lot of hope there. There's a ton of hope there.
And that's where he needs to go is, not how long can I live? What do I need to do today to start turning this around? Right.
Yes.
And that's a different mindset. Like an interview I did with Clark Bartram. He had the 5 things, and one of them is mindset. That's where he starts. When he got his diagnosis, he just immediately knew he needed to level up his mindset and get in the right frame of what am I thinking about? What is important? What do I need to do? And make an action plan. And that's where we need to be. Which can be tough because the diagnosis can put us into shock. The diagnosis, we may not I look back and I think I was in shock for probably longer than a week, probably longer than a month.
Oh yeah, completely.
Yeah, I didn't completely understand my situation. And then I went from really lighthearted about it to really dark about it before I finally centered on, oh, wait a minute. No, I'm hearing what people are saying. Now I'm reading on my own. Now I'm finding information. So it took me a long time to get to that right mindset. So by the time I started these episodes, I was getting there. And yeah, I think you're right. I think he's asking the wrong question.
Well, Jason, too, you're as another example, and I say in my last episode, I didn't really, because I was in shock. I really did not know how sick I was until I reread that PSMA PET result and really understood kind of what it was telling me. Another reason for, I would say, because yes, and I think you were alluding to this, when I was first diagnosed, that question, I had the same question. How much longer do I have? Do I need to just stop everything right now and then just be spending all that time with my boys and my family? And the answer is no, especially with prostate cancer. And I've said before, you don't want cancer, but if you have to have a cancer, you want prostate cancer and you want it now because we have so many things available to us. Another thing that I would say to the person who asked that question is be careful about looking online, for answers to that question. Yeah. And the reason being is because so many of these treatments that are now available to us are so new. What you're reading about how long you have to live is based off of treatments 10 years ago, 15, 20 years ago, where, 20 years ago, you may have had a 30% chance to live in 3 years. That's not the case now.
Nope.
That is not the case. And look, your PSA at 50, man, I wish my PSA was 50 when I was diagnosed. But because other than the PSA, I'm that guy. I'm that guy. Except my PSA was 570. So, you got hope. That shouldn't be the question you're asking. You were exactly right. Ask the questions that Jason was just saying.
All right, we got one more here. Yeah, this is one I'm asking as well. This is one I'm starting to think about, and you clearly are too. Yet, when do you declare you are cancer-free or a survivor?
Yeah. So the clinical definition is that you've survived for 5 years. You don't even need to have the cancer completely gone. You're just a cancer survivor if you've lived 5 years after diagnosis. That's the technical meaning.
Now, is that with treatment or like if I'm surviving 5 years with treatment? I think it's without treatment, isn't it?
No, I don't think so. And I could be wrong, but I think the technical thing is 5 years after diagnosis, period.
Oh, well, there's
a cancer survivor.
There's our first goal, 5 years.
Yeah. But I mean, I think about this a lot too. So it's really, what is it going to mean to you? Yeah. For me, cure and remission, I think they're very close.
Yeah.
And I think for me, it's going to have to do with me being, number one, off of ADT for a prolonged period of time.
Same.
And not having discernible Mets. I think if I can achieve those two things, that's cure. And of course your PSA. The PSA is the iffy one because, you hear these oncologists who've been around for a long time talk about patients they've had who've got PSAs of 20 or 25 who they keep doing scans on and they can't find any cancer.
Yeah. Some people just have high PSA. There was a guy I was talking to his normal PSA is 6. Yeah. Like I had metastasized prostate cancer at 4.2.
Yeah.
What the heck? Everybody's
different. What does cure mean for you?
Well, for me, I've got to be off ADT. I've got to be off the hormone treatment. And if I'm off the hormone treatment and in my mind, I'm thinking 2 years. If after 2 years of checking my PSA, eventually they're going to go from checking 3 months to 6 months to yearly. So if I get to that 2-year point after ADT and my PSA is still, well, I guess it's not going to be undetectable because I didn't do surgery. So it's going to come back up a little bit.
Yeah.
But it needs to plateau. It needs to plateau really, really low. So after 2 years off treatment with a steady PSA that's low, I would consider myself cured.
Here's a better question.
Yeah.
What are you going to change when you consider yourself cured? Like, are you going to change your diet? Are you going to change exercise?
Well, what I think, I credit my diet significantly to my how fast I got my PSA down, how well I've responded to treatment, that these issues, I'm not having a whole lot of issues, and I credit my diet to that. So I'm not going to change my diet significantly. Is it going to widen a little bit? Yeah. I mean, I went out to breakfast yesterday morning, and I've been trying to do no eggs, no dairy, and try and do primarily, plant-based proteins. And I went to a place here in the Tri-Cities called Endive, and I had what they call a Bene Slammin, B-E-N-E Slammin. And
I
it's
think I saw a picture of this.
yeah, smoked salmon, poached eggs, a house-made cream sauce, so it's a little bit of dairy. It's got the eggs, but it has sprouts, tomatoes, relish, a tomato relish. It's got some smashed potatoes instead of bread, so there was no toast, no bread. It was still overall really good. Is it a little?
It looked good.
It was that place makes some good food. Does it veer off my what I'm trying to do for my diet? Yeah, but I think that's where I'm going to be. Is I'm going to have a mainline goal, and I'm going to allow myself a little bit of variance, and if it ever comes back again, that I go hardline.
Yeah, I think you're right. I think for me, I don't think a lot's going to change for me. I don't plan on ever doing dairy again. I have read too many things about it, and I just feel too good. I think if anything, maybe I'll do a little bit of gluten. I don't know about the alcohol. I really don't. That's a touchy thing with it because I do enjoy it. Enjoy beer every once in a while. I think I mentioned before I got the diagnosis, one of my goals was opening a distillery. And of course,
yep.
Not drinking alcohol kind of puts a damper on that.
You come up with some funny names, though.
Yeah.
it's the I don't drink this beer.
Yeah, exactly. That's good. But as a complete aside, nothing to do with cancer. It seems like this generation, the younger generation, they are more into these mocktails and the non-alcoholic. They don't drink a lot.
Yeah.
Which is
they've seen what it did to our generation.
Yeah, maybe that's what it is.
Yeah,
maybe that's what it is. So, but
one of the things my radiation oncologist said about alcohol was, he says, if you drink, he says a couple glasses of wine won't hurt. In fact, it may have some health benefits. He says there's a lot of data out there that supports a glass of wine, a night, or a couple glasses of wine a week. So maybe that's an option, is shift, get away from the beer and become a wine snob.
Well, that's, my father-in-law is, and by all accounts, a wine aficionado.
There we go.
but he and they drank a lot of wine. They do. And they're very healthy. And obviously they're older than we are. I think they're in their 70s. And they drink a lot of it, and they're very healthy and have had minimal health issues.
Oh yeah, look at all of Europe. Look at all of France.
Yes, I think back in the medieval times. I mean, those guys were not okay. Their life expectancies were a lot less back then too. I mean, these guys they were only living to 30.
Yeah,
but so maybe before I say hey, that's what they were drinking back then. Maybe they were only living to 30 for a reason.
Well, we're getting a little over an hour here. One of the things I want to touch on is where to find info. And you've already mentioned most of the spots. Google, or go to YouTube, go to Google and look for Dr. Kwan, look for Dr. Gio Espinoza, look for Dr. Schultz, PCRI.org. Look at anything on the Mayo Clinic, the Cancer Research Institute. Those are the sites to go to get your info. Don't go to Dr. Google. Don't go to the prostate cancer forums on Facebook. You might get some good info, but you're at risk of getting bad info. So, but hey, this has been a fantastic conversation. This is a good way to finish out my 20th episode. I think I am going to do more. I think there's going to be a 21.
Maybe just take a break. Who knows? I think it was a month and a half between my last two or something.
There you go. Yeah, maybe I'll just focus on the rockets a little more for a bit.
Yeah, those would be great videos. Like I said, I want to see them. I'm a huge fan of October Sky.
I love that movie.
Yeah.
Love that movie. I'm not making my own boaters from scratch with the potassium nitrate and the sugar, the powdered sugar, and the fertilizer. I'm not to that level yet, but fun stuff.
Yeah.
Well, hey, Stick around a little bit here afterwards to make sure this uploads, but
Yeah.
we'll say goodbye to everybody else. Any last words you want to tell everybody?
Sure. Just whatever anybody's going through, just remember all the time, anything is possible.
I love that. All right. Well, thank you, Adam. Thanks for being here.
Thanks.
All right. Thanks for watching. Thanks for listening. Love you all.